Hello, welcome to AETCM. Today we're going to discuss a case about an 85-year-old male who was brought into our ER in a gasping state.
Okay.
The patient was brought into an ER in a gasping state. The short history we got was that the patient had an acute onset of breathlessness for the past 12 hours.
Okay.
Initial assessment, the patient was gasping and then the patient became unresponsive and was not breathing.
Okay.
And
So
carotid pulse was absent.
absent. So you have got a patient who is having an abnormal breathing. So that you can, rather than calling it as gasping, you can call you have received a patient with abnormal breathing pattern, which doesn't look like normal. So that is the history that you got. So suppose you see a patient like that, what will be the next step? You are seeing a patient with abnormal breathing in front of you, whether it can be a jaw breathing or gasping, or either can be a tachypnea. What will be your next response?
Immediately you should give him oxygen.
Okay, see, an abnormal breathing will not say that the patient is having a pulse. A gasping patient can have an absent pulse also. So whenever you see a patient who is having an abnormal breathing, or as you said, gasping, the next response, you just remember your BLS algorithm. Even if the patient is responding or he is having some activity like breathing, abnormal breathing, go and do the pulse check first. I'm not denying the fact that he needed supplemental oxygen. That is not the fact that I am denying. But that patient might be in a cardiac arrest. So by going for an oxygen, we might miss a totally a cardiac arrest. So even cardiac arrest patient can have gasping breathing. Or there may be in PEA, that phase. So whenever you see an abnormal breathing like this, as you said, a gasping, the first response, you just check for the pulse immediately for 5 to 10 seconds. Meanwhile, you arrange for oxygen, maybe back mask ventilation at that time. That all depends upon whether there is a pulse is there or not. If there is pulse is not there, then the total algorithm changes. The pulse is there, the next thing will be initiation of CPR and supplementing 30:2 compression with ventilation ratio. So that is the first step that you should do. Sir, any points? Sir?
Correct.
Okay. So first you remember this. So abnormal breathing, gasping, immediately check for pulse. In the BLS algorithm, what we already learned that unresponsive patient, check for pulse. It is unresponsive can be there or it can be an abnormal breathing also. So abnormal breathing will not guarantee you a normal heartbeat or it cannot be a bradycardia. It can be a cardiac arrest also. Okay, continue.
So patient pulse was checked and carotid pulse was absent, sir.
Okay.
And following it, we started cardiac resuscitation according to ACLS protocol.
Okay, now we'll we'll start discussing here. So you have seen this patient, as we told, there was no pulse. So where will you check for the pulse?
Carotid pulse will be the.
Carotid pulse. Why carotid pulse?
It's most near to the heart.
See, when we studied our MBBS, where we'll check for the volume, it is in the carotid pulse. So it is the first pulse to reappear and last pulse to disappear in a case of a cardiac arrest. If there is low volume also, you might be able to get a carotid pulse. Suppose the patient has been brought in hypotension, you are not getting any peripheral pulses. When you check for the carotid or maybe femoral, sometimes you will be able to feel it. So that is the reason why we are selecting carotid pulse. So carotid pulse is the area that you need to check for pulse. Then how long you should checking for the pulse?
About 10 seconds.
Not more than 10 seconds. But not less than 5 seconds. So that is the algorithm. You remember the BLS algorithm. 5 seconds is the minimum time that you need to take and not more than 10 seconds. So 5 seconds you have examined, there is no pulse. Immediate next step, since you are in the emergency room, you are all the help around. But you are in somewhere else, the algorithm says that you have to call for help. And initiating the CPR. So how will you initiate the CPR?
So initiating CPR, we should call for help.
Okay, the help is already around in the emergency room. There are EMT technicians, there are a lot of paramedics, there are other colleagues available. So, what are the other things that you need to do?
We should have a CPR board also.
Okay, that is the other thing. You have to keep the patient beneath the CPR board and the patient should be lying supine over it. So that the compression, whatever you are going to give, will be an effective compression. So, that is the next thing. Then
the compression should be at a rate of 120 beats compression per minute.
100 to 120 compressions in a minute. Yes. And you should be giving compression in the center of the chest with the nipple line in the center of the chest, not to the right, not to the left, the center of the chest at a rate of 100 to 120 compression in a minute. Then what should be the depth of compression?
Depth of the compression should be at least 5 centimeters.
5 centimeter. And next thing,
It should be given at the rate of 30:2.
okay, 30 compression followed by 2
Two
rescue breaths. Okay, fine. Then
It should be
what are the other things that you need to consider while giving compression? You have to avoid what all things?
avoid any unnecessary interruptions, sir.
One minute. Before going that, how many rescuers are here now? They'll with you. Are you alone?
Sir,
Lone
about
rescuer or
six
more
person.
here? So you can organize a team.
Yes, sir.
So immediately you call the team and allot the work. If you are taking over the in charge responsibility, okay. So that will avoid confusions. Or somebody will be 2 or 3 people in the head end, like that. Okay. In the CPR protocol, what does it say? That same protocol you adhere to and form a team. Okay, then proceed.
You should have a team dynamics and you should clear roles and responsibility. That is exactly because when you have receiving a patient before itself, you should have a plan that, okay, when a patient is coming with a crash, you should take care of the airway, you should take care of the drugs, you should take care of the compression, you should take care of the defibrillator, you should be noting down the time, and one person can be the team leader. So totally how many people are needed? Minimum is 6. So these are the 6 job responsibility, and the airway person and the compressor can interchange in between the 5 cycles between after 5 cycles or whenever they feel exhausted. So that is the usual pattern. So the most important thing, clear roles and responsibility. Between the team members, you should not be assigning a role to a member that he doesn't know to intubate. You should not ask him to take care of the airway. He should be able to do how to do a back mask ventilation, how to give a proper ambu bag ventilation, how to intubate, all those things he should be knowing. And a junior person who doesn't have any practice in loading the drugs should not be doing the drugs. And defibrillator, what all things should be done exactly as per the jobs and responsibility. If they know, they have to clearly understand what is their responsibility and they should be doing that also. So that is one most important point what sir have said. Then coming back to the CPR, you said 30:2 the compression, center of the chest, avoid interruptions. If at all there is an interruption, the interruption usually comes between the pulse check or the rhythm check. So maximum allotted or permitted interruptions is 10 seconds. So within that you have to restart the CPR. Next thing,
The compressions are given at for about 2 minutes. Or
no, what else you need to do while you are giving your bag mask ventilation?
Avoid excessive ventilation.
Avoid excessive ventilation. Then, while giving compression, what is the next most important thing that you need to see?
You need to provide adequate time for chest recoil.
Recoil, adequate time for the chest recoil. So these are the, as we call, qualities of CPR. Whenever we discuss the qualities of CPR, remember the rate, the depth, the interruptions, avoiding the excessive ventilation, and you should give adequate time for the chest to recoil also. That is a time when the coronary perfusion occurs. So during the recoiling phase only the coronary perfusion occurs. So the most what will happen when the team member is so much excited that he is the first time he is doing CPR, he will be very much excited and he will be giving at a compression at a very fast rate and he will not be giving adequate chest recoil also. So that is not correct. There is something called as chest compression fraction. Chest compression fraction should be around 70 to 80%, at least 65%. So that is what you mean by chest compression fraction is that the amount of time when you are taking a cycle of CPR, it is 30:2. So suppose you are giving 5 cycles of CPR, that is taking you 2 minutes. So among this 120 seconds, you should be devoting around 80% of your time for giving the compression alone. So that is what is called as chest compression fraction. So when you have got a good chest compression fraction, when you are maintaining at a speed of 100 to 120 compression per minute, you are going to achieve that CCF of 100 to 120. You are able to achieve a CCF of around 80 to 85%. That is why the AHA has recommended that this should be the rate of giving the compression. So maximum time you are giving should be utilized for giving your compression. So when you are doing minimizing the interruptions, you are doing all other things, you are decreasing that interruption time, so the CCF will improve. That is called as chest compression fraction. Okay, so you have to remember, so whenever you are giving breath, back mask ventilation, what are the things that you need to consider? How fast, how should you use your back mask ventilation? Each breath should be delivered over a time of 1 second. Each breath should be delivered over a time of 1 second. So that is the thing. So when your 30 compression is over, at the count of 30, the person who is going to give the breath can keep the face mask over the patient's face, deliver 2 breaths, and after that resume CPR immediately. Like that, after 5 cycles of CPR, you reassess the patient, and meanwhile the person within the compressor and the airway person can interchange also. So you are minimizing the interruption. So we have 10 seconds only. Within this 10 seconds they need to interchange and resume CPR, and one person have to do the pulse check and other person have to do the rhythm. If you're connected to the defibrillator, you have to see the rhythm and simultaneously you have to resume CPR also. So that is a 10-second gap. Okay, so what we did for this patient?
We started the CPR, sir.
Okay.
And also alerted the staff and ambient ventilation was started. And we connected to the patient to defibrillator.
Okay, as soon as the machine is available, defibrillator is available, the next thing is you connect it to the defibrillator, and once you connect it, you have to hold the CPR and see whether the rhythm is a shockable or a non-shockable rhythm. That is the next step. So we have stopped the CPR and we have seen what is the rhythm, whether it's a shockable rhythm or a non-shockable rhythm. So which are the shockable rhythms?
VT.
Ventricular tachycardia and ventricular fibrillation. In general terms, we can call it as wide complex tachycardias. When you see a wide complex tachycardia in a patient in cardiac arrest, that is a shockable rhythm. So what happened to this patient? What was the rhythm for him?
The patient was not on any rhythm, ASYSTOLE, sir.
So it was ASYSTOLE. So there are two rhythms, that is 4 rhythms when you can see is pulseless electrical activity, asystole, and what else we can have is a VT or a VF. So what we have done?
Patient had an ASYSTOLE. So we continued the CPR and IVSS was obtained and injection epinephrine was given at the 1 mg, 1 ml, 1 into 1000 IV given, sir. And
so what preparation available? There is a lot of confusion that what we are going to give this patient, what is the dilution of epinephrine. There is no confusion in it. 1 ampule of epinephrine is 1 in 1000 dilution that is available, that is 1 mg. So you give it as a 1 mg IV stat followed by 10 to 20 ml of saline flush. So that is the next step. So every 3 to 5 minutes you can repeat epinephrine. So that is a drug that you need to remember in asystole and PEA. There is only one drug that you need to repeat every 3 to 5 minutes is epinephrine. 1 in 1000 dilution every 3 to 5 minutes.
And one patient was also sent for asking the history from the bystander, sir.
Okay, so simultaneously there is you have enough team members, so other person can start collecting the sample history also. When we discuss according the algorithm, the team leader should not be moving away from the patient. You can send another person and you can collect the history also. And meanwhile, what will be a next concern? Next concern, we have started the CPR, you have given your adrenaline, you have checked the defibrillator, that is not a shockable rhythm. You need to find out why he had a cardiac arrest. You need to remember the 5H and 5Ts of cardiac arrest. So which are the 5H and 5Ts?
5H include hydrogen acidosis, hypovolemia, hypoxia, then there will be hypokalemia, hyperkalemia, hypothermia.
Hypothermia.
5 T's include tension pneumothorax, cardiac or pulmonary thrombus, cardiac tamponade and toxins.
Okay, excellent. So you have to look for the cause of cardiac arrest. So you need to discuss within the team member why he developed this cardiac arrest. For that sometimes you need some investigations. You need to send a blood gas. So you need to look into the blood gas and see what is happening, whether there is any evidence of hyperkalemia, whether you can get back somebody you have sent back to collect the history. He's coming back and giving you something clues why he developed cardiac arrest. Maybe you can get your ultrasound machine immediately and see for any evidence of cardiac tamponade. All those things should be, you have to look for the cause of cardiac arrest. Unless and until you are doing that, you will not be finding any cause for cardiac arrest. Sir, any points, sir?
Okay.
We also looked for in the take a ABG and also GRBS, sir. GRBS was 220 milligram and a
blood gas.
Blood gas ABG showed respiratory acidosis, sir.
Respiratory acidosis. Can you just tell me the pH readings?
pH was 7.19, PCO2 of 94, PO2 of 12, bicarb of 26, and
so it can be a VBG or an ABG. So whatever be the reason, there is acidosis. Even if 96 is very high, even in a VBG itself, PCO2 of 96 is on a higher side. So it's from the history, whatever available, whatever we are seeing right now, it looks like a respiratory acidosis. So can you presume what will be the cause of cardiac arrest? Primarily, we are looking into a patient who had an hypoxic cardiac arrest. We are presuming, we are not very sure. We didn't have any other clue because he might have developed a respiratory fatigue and he went into a respiratory failure. And from that respiratory failure, he has went into a respiratory arrest, and respiratory arrest led to cardiac arrest. And he is in front of you. That is what we are trying to get. So now why he developed this respiratory failure? That is the question. Now, we have started resuscitating. So, how long we resuscitated him?
We resuscitated for about 2 cycles, sir.
Not 2 cycles means 1 cycle means 30:2.
2 minutes.
2 minutes. So approximately you have given 10 cycles of CPR. So you have given nearly 1 dose of or not 2 doses of epinephrine.
And CPR was continued, and one second dose of adrenaline was given, sir. By that time, we got the history from the bystander, sir. He was a known case of CAD, status post CABG, sir.
Okay.
With COPD, CKD, and he was also on BiPAP during the night. And he had the main complaint was he had acute onset of breathlessness, which increased over the night, and so he came. Without using the BiPAP, he came to the hospital, sir.
Okay. So he was on a continuous BiPAP and an oxygen support, to be very frank. So BiPAP was using in the night time, and daytime he was using his oxygen support. He had a bursting of breathlessness, so he was shifted from his home, and in that hurry they missed to keep his oxygen. So they just came in and he was brought in cardiac arrest. So primarily we are getting a reason for his cardiac arrest looks like a hypoxia. So that doesn't mean that all other causes of cardiac arrest are ruled out. It can be still a tension pneumothorax or a pneumothorax which is related to tension and went into a cardiac arrest. That is also a possibility here. We can't just say that it is due to this, but meanwhile you can just put your ultrasound machine and see how is the lung sliding and all. If you are able to while doing back mask, it is difficult, but once you are intubating the patient, it will be much more easier. But again, intubating it tension pneumothorax, that is a question. So it's a vicious cycle, which is a very difficult question to be answered. So once you see there is a cardiac arrest, you resuscitated the patient, and once we have got something called as an ROSC, return of spontaneous circulation. Meanwhile, you can look for the causes of the cardiac arrest, and you got a cause probably primarily due to hypoxic cardiac arrest. Sir, any questions?
So, where was his house? How long it took for shifting the patient?
House was near our place only, sir. It's about 30 minutes from here.
30 minutes. So he was deprived of the BiPAP for 30 minutes and oxygen. Okay.
Okay. So the next thing is I want to just ask you, what is the role of end-tidal carbon dioxide, ETCO2, in a case of a cardiac arrest?
ETCO2, by measuring the ETCO2, we can know whether patient is intubated or...
First of all, you have to intubate this patient to get an ETCO2. In a cardiac arrest scenario, without intubation, you are having no clue because nasal interface will not be working to that extent. Or else you can connect it to the back mask ventilation, but it is also, again, when you squeeze it more faster, it will give a lesser reading. But once the patient is intubated, you can connect the ETCO2. So first thing, it will help to know the position of the endotracheal tube, whether it is in the right place, whether it is in the trachea or is the esophagus. You can look for the tracings, and reading also we will know. Second thing,
CPR is adequate or not, we can...
you have to be very specific. Quality of CPR. Whether CPR you are giving, somebody is giving the CPR, whether there is any quality issues. You ideally should have a feedback device. There are different feedback devices, either a wristwatch, sort of a band which gives a color coding, or there are certain devices which you can keep over the patient's chest and know this. But you need to check for the quality of CPR. One clue is ETCO2. If ETCO2 is persistently less than 10, that means your CPR quality is not good. You need to improve the quality of CPR. So next thing, what does it help? ETCO2. Suddenly you are doing CPR. Suddenly the ETCO2 is jumped to 45-50. So what does that say?
Patient became
return of spontaneous circulation. And after 20 minutes of CPR, the ETCO2 is not increasing. What does that say? There is chance of survival is less. So less than 10 ETCO2 for a prolonged time, after 20 minutes you are not able to improve the ETCO2. That means the chance of survival is less. Recovery from this cardiac arrest chances are less. So we have a gentleman who has come was on a BiPAP on an oxygen support which was removed, and he was brought in from home due to breathlessness. Meanwhile, he was brought unresponsive, and also he has an abnormal breathing, and there was no pulse. You initiated the CPR, and after 10 minutes, nearly 10 minutes of CPR, we achieved the return of spontaneous circulation. So once you achieve return of spontaneous circulation, whether he was intubated in between?
Yes, after attaining this, ROSC was attained, patient was not breathing.
Okay,
So
definitely he will not be breathing at this point of time. We can't continue with back mask ventilation also. Suppose definitely we need to secure the airway at this point of time. See, my question is when to intubate in case of a cardiac arrest. So everybody thinks that intubation is the first treatment that you should do in a cardiac arrest. Many people are there. I'm not denying the fact. Many of my colleagues are still in the feeling that intubation is the first thing that you should do while in a cardiac arrest. So what is the recommendation? What is the evidence says?
according to ACLS, sir, we can start our CPR. Is if it is a non-stop like this is a ASYSTOLE patient, we can start our CPR and give first dose of epinephrine. Followed by we can think about giving the advance.
See, you can think about definitive airway at any point while doing resuscitation. I am not denying the fact you can, whenever it's possible, you can think of a definitive airway. But for definitive airway, you should not be wasting your precious time of doing your CPR. So, whatever be the 10-second time frame, you need to intubate the patient. If you're able to do that, okay. But without, you can't, prolonged interruption should not be done. And even if you're able to do a good back mask ventilation, like what we did for this patient, we got him back, then only we intubated. So that is not like intubation is the primary focus, but definitely when you are suspecting an hypoxic injury, like in this patient, but still we got him back. So intubation should be done. I am not denying the fact, but intubation can wait till the ROC is achieved, or without interrupting the CPR, we can go ahead and intubate. That is why it is CAB, circulation, airway, breathing. So circulation is the priority, compression is the priority in a CPR. So without interrupting the CPR, if you are able to do that, well and good. But with interrupting, no. About 10 seconds, no. So evidences also shows the same. If you are able to do a good back mask ventilation, that is fine. The only advantage is that when you have a definitive airway, your respiratory, you need not plan your this thing along with the compression. You can continue giving compression at a rate of 100 to 120. That 30:2 thing is not needed. Every 6 seconds only you need to deliver one breath. There are ventilators where which you have CPR mode. You just switch on the CPR mode. The ventilator will give breath every 6 seconds. So that is the idea of doing the intubation. Okay. Now what after cardiac arrest, after achieving ROC, what you have done to him?
After attaining, we connected him to ventilator, sir, in PCV mode. And
so first of all, what you have to do, you have to reassess the vitals.
yes,
That is the first step. Once you achieve ROC, you have to go back, see the pulse, see the blood pressure of the patient. What is the saturation? There are certain targets that we need to maintain. So you need to go for the post cardiac arrest care. So certain target that you need to achieve. You need to have a map of above 60 to 65. Then you have to attain an BP above 90, systolic blood pressure and saturation of around 95%. That is the targets that we need to maintain. So you have to maintain these targets. For that, you need to give sometimes IV fluids. You need to sometimes give some vasopressor agents. Whatever be the thing, these are our targets. And since we have found out a cause of cardiac arrest in this patient, treating the hypoxia, we have already done that by doing an intubation to this patient. And whether it is an MI related, that patient should be shifted to a cath lab. And after that, you should see whether his sensorium is getting improved or not. If no improvement in sensorium, is not regaining his consciousness, what is the next thing that you need to do is targeted temperature management, which recently doesn't show have got such improved outcomes, but still in AHA recommendation, for the next 12 to 24 hours, you need to go ahead with the targeted temperature management of 36 degrees, 34 to 36 degrees. At least you maintain normothermia. So these are the things TTM. And if after some time also he is not regaining consciousness, think about EEG, brain imaging and all those things. So that is in a nutshell regarding our post-cardiac arrest care. What happened to this patient?
patient was revived from
and he was shifted to the ICU. Okay. So after that, we have handed over to the critical care. Sir, any
How long CPR was continued?
Sir, CPR was continued about 2 minutes, sir.
2 minutes immediately.
2 minutes, approximately 10 minutes. No, you said 5 cycles.
5 cycles.
2 doses of adrenaline.
2 doses.
So first dose of adrenaline, definitely it will be after 3 minutes. So around 5 cycles plus 5 cycles. It will be approximately 4 to 6 minutes.
So the primary importance is chest compressor. So in between with the least interruption, we can go for the intubation. But 85-year-old man, less sometimes the mask fit. You have to be giving adequate precaution to hold the mask tight. Otherwise, when you are bag masking, most of the gases will be leaking. It will not reach the chest. And in addition to the ETCO2 value to confirm, The tube is in situ, that is exactly in the trachea. So you have to auscultate also in all areas over the chest. So it may be going for one main bronchus, especially right bronchus. Then also you will get the ETCO2 value. But now we can correct it and bring it just above the carina, 2 or 3 centimeters above. Okay.
Okay. Thank you.